Friends, Warren, and then start in next 1 minute. All right, a very warm welcome to everyone who's joined this session of the Global Academic Radiology Education Program. I'm Dr. Punathapura JP. I'm one of the radiologists at Wake Forest University School of Medicine from Winston-Salem, North Carolina. So, very brief introduction about AREP for the first-time attendees. So the Global AREP is a nonprofit initiative which is aimed at providing high quality education to colleagues worldwide. So we established in October 2021 and it based at the Department of Radiology at Wake Forest University School of Medicine. We offer free online education resources and live webinars, which features academic radiologists from leading US institutions. This program is designed to bridge education gaps, particularly for radiologists in resource-limited settings, by sharing expertise and fostering global collaboration. So we host bi-monthly webinars from January to October, and we cover various radiology subspecialties. And these sessions are very well attended when up to 700 participants per live event. And we have contributions from esteemed institutes and radiologists in different countries in Asia, Africa, and Middle East. And this program's success is driven by the dedication of its committees, moderators, speakers, who work tirelessly without external funding. And in addition to webinars, ARDP also offers projects like Radiology Excellency Program, which focus on mentoring and specialized radiology challenges in various countries. So once again, I'd like to welcome you all for this wonderful session. This is the last musculoskeletal session. And our session today is moderated by Dr. Undrek Erdenbold. And Dr. Erdenbold is a diagnostic and intervention neuroradiology. He's an assistant professor in Department of Radiology in Dalhousie University in Halifax, Canada. Not only that, he's also founder and president of the Mongolian Society of MRI in Medicine and founder and secretary general of the Mongolian Journal of Radiology. All right. Over to you, Dr. Erdenbold. Thank you.
Thank you, JP. I hope you guys can hear me well.
Yes.
Okay, so again, hello everyone, and welcome back to the this wonderful imaging academic radiology education program. And today's our guest speaker is Dr. Octavio Arevalo Espejo. So his work is focused on advanced brain tumor imaging, MR spectroscopy, and MR perfusion weighted imaging, functional MRI, head and neck imaging, and visual imaging. And then he works at the Ochsner, Louisiana State University Health, Shreveport, Louisiana. And today's his topic is imaging in low back pain. So thank you so much, Dr. Espejo, for your time and for your presentation to our audience. And stage is yours. Welcome.
Thank you very much, Dr. Erdenbold and Dr. JP for the REP committee for the invitation. It is a pleasure and an honor for me to share these few minutes with you this morning in the US and evening over there. Today I'm going to talk about the imaging of the degenerative disease of the lumbar spine and how it relates to the low back pain symptoms. And I have no financial interest or relationships to disclose. Well, pretty much the objective of my lecture is to just review the relevant like the very basic concepts in anatomy, physiology, and pathophysiology of the imaging findings of the degenerative disease of the lumbar spine. There is obviously much more real estate to cover, but I'm just going to try to summarize all the important topics in less than 45 minutes. So it becomes useful for a broader audience. This is the outline of my lecture today. We're going to talk about the characteristics of low back pain, just like a few slides. Then I'm gonna review like some topics about degenerative disc disease. I will also talk about degeneration of the posterior elements, and the very last few slides are gonna be about spinal canal stenosis. And well, let's get started. So low back pain. The definition is just a pain, as you may imagine, like due to either muscle tension or stiffness that is localized below the costal margin and above the inferior gluteal folds. It is associated, sometimes it's associated with leg pain or not, and that's pretty much the clinical definition. And then we can classify the low back pain into two different groups. The first group is specific low back pain, and it's less than 10% of the patients. It's not the rule, it's like the exception. And usually the symptoms are caused by a very specific pathophysiologic mechanism, like a herniated disc, infection, fracture, a tumor, they're like something that is the direct culprit of the pain. However, the vast majority of the patients present with a non-specific low back pain, like 90% plus. And this, in these patients, the symptoms do not have a very clear or specific cause. This type of low back pain has a good prognosis. Patients usually recover within weeks. And there is a very, in yellow, I highlighted there is a weak correlation with imaging abnormalities. And that's very important because as we will see later on, the degenerative changes of the spine may overlap with the normal aging findings. So that's very important, and we have to have that take that into consideration. So many people without any symptoms also show like similar abnormalities. So, and according to the duration, the low back pain can be classified as an acute, subacute, or chronic with different management strategies. So what is the role of imaging on these patients? So we have, like, as you know, like a very, very extensive armamentarium of imaging to evaluate these patients. We use X-rays, CT, MR, nuclear medicine studies, and then, but the problem is that imaging in low back pain does not necessarily improve the treatment outcomes of patients that are younger than 50 years of age with no signs or symptoms of any related systemic disease, either an autoimmune process or cancer or like an infectious process. And there is something that is very important, and is that advanced imaging should be reserved for patients who may be candidates for surgical intervention or in patients in whom a systemic disease is strongly suspected. Because this is very important because the imaging resources are limited. And if we start imaging all of these patients with no risk factors and no other suspicion for like an underlying etiology for the low back pain, then we are going to overwhelm the system and just spend the resources, waste the resources, right? So that's it for low back pain. Now let's focus on degenerative disc disease. So I just wanted to touch base about the anatomy of the intervertebral discs. The intervertebral discs are located in between the vertebrae, right? And they are located between the hyaline cartilage of the end plates of the corresponding vertebrae. They have two main functions. One of those is shock absorbers, and the other one is to allow motion, of the spinal column. They have two components, the annulus fibrosus and the nucleus pulposus. And the annulus fibrosus is made mainly of collagen times 1 and 2, and they are made of multiple concentric layers of fibrocartilage. And the outer layer is, in continuity with the Sharpey's fibers, which are the ones that attach the periosteum to the actual underlying cortical bone. And they're also fused with the anterior and posterior longitudinal ligaments. Whereas the nucleus pulposus is highly elastic, is very watery, it has a lot of proteoglycans and loose collagen fibers. And the water content of the nucleus pulposus decreases with age, being 90% at birth and 70% by the fifth decade. So this is like an image of the Netter's atlas. We are all familiar with it. I just wanted to show you what the nucleus pulposus was. It's in the center of the disc, and then the multiple concentric layers of the annulus fibrosus, which are like perpendicular to each other, and how the superficial most layer of the annulus fibrosus merges with the Sharpey's fibers of the adjacent vertebrae, as well as with the anterior and posterior longitudinal ligaments, as we can see here. Right here on the axial plane, you can see this area of prominent bone here that limits the intervertebral disc space is called the ring apophysis. And this area here where you can see cancellous bone is covered by the hyaline cartilage of the end plate. And here you can see the pedicle, the lamina, and the facet joints, that are going to be important for us as we continue our discussion. There is this very nice paper by Dr. Jenkins published in the European Journal of Radiology in 2006. It's pretty old, but it's so nice. This is the PMID. If you're interested, I strongly recommend it. And I'm gonna use his illustrations a lot because I think those are very educational. This is the midline view of the lower lumbar spine. And then we're gonna walk over this anatomy later on the drawings, but I just want you to see with the number 17, this is the nucleus pulposus with the number 30. I may use this, the laser pointer better, the pronto you can see it better. So the number 30 is the annulus fibrosus. And then you see on number 4 is the posterior longitudinal ligament. And then you see on the asterisks is the interspinous ligament and so forth. So we're gonna go over this in detail later on. All right, let's talk about age-related changes in the intervertebral disc. So infants and children, the discs are prominent. And by prominent, I mean they go beyond the limit of the vertebral body on MRI. And just think of the ring apophysis as the quote unquote growth plates that you see in long bones, right? So these are the areas for the centers for ossification and growth. So the ring apophyses are a little bit more prominent than the actual vertebral body in the sagittal dimension, right? So they are prominent and they are dark on T1 and very high signal intensity on T2 because of the water content. You remember I was telling you that in kids, you know, when you're born, the nucleus pulposus is 90% water, right? And as you grow older in young adults, the signal intensity remains pretty similar on T2. Is pretty high because of its high water content. However, the T1 signal intensity decreases, okay, increases. So it is no longer like the CSF, but a little bit hyper intense, but it is also hypo intense compared to the bone marrow. That is very important. It's one of the internal references that we have to evaluate bone marrow signal intensity. So, but you see that since the growth has probably stopped or its speed has decreased, now the disc space kind of lines up with the vertebral bodies, right? So the discs are no longer that prominent. And in the 3rd to 4th decade, then the T1 signal intensity decreases. It's pretty similar to that of the muscle. And the T2 signal intensity also decreases, but it's still high. And, you know, in middle-aged adults, you start seeing these little hypo-intense cleft on T2 that you didn't see in young people. You see the there is no cleft here on T2 in young adults, but as you grow older, then your nucleus pulposus starts to lose water. So your disc becomes a little bit more hypo-intense on T2, and that's normal, that's aging, that's just aging. And then when you are like a senior citizen, then you start seeing that the signal intensity on T2 is low as well on T1. You see that the vertebral body is a little bit more bright on T1. That's because of progressive fat replacement of the bone marrow. That's normal as well. These are normal changes, normal aging changes. Here you can start seeing like some spondylolisthetic changes, like some osteophytes as well, and some minor just annular changes as we are going to see later. But this is just the normal aging process of the discs. What is the pathophysiology? Pathophysiology of the degenerative disc disease. So some people say, well, there's like a perfusion hypothesis, there is a biomechanic hypothesis. So what the perfusion hypothesis says is that there is progressive loss of blood supply to the disc during childhood. You know, as the hyaline cartilage of the end plates becomes more harder and ossifies, then the passive perfusion that happens through the hyaline cartilage into the disc stops, and then that diffusion of nutrients, you know, degenerates. It stops, and the deficit degenerates the disc. And but there are some people that say, well, that can be just genetics. There are some people that are more prone to get degenerations, and some people say, okay, that's beyond biomechanics. Because of the progressive desiccation of the nucleus pulposus, it results in loss of height and elasticity. And then it results in a poor shock absorbing performance. And some people say, well, depending on the location of the disc, there are certain discs that are more prone for degeneration, like the mid-cervical spine and the lumbosacral junction. That also plays a role. And there are also some people say, well, there is like an environmental component to it, because if the patient is like a weightlifter, or is a patient, or say like a driver, like a truck driver for like a living, the person just remains seated for hours on end, or the patient is obese, or the patient has atherosclerosis, the patient is a heavy smoker, all of those factors also contribute. So when you have like many hypotheses, probably, you know, the truth is probably like a combination of all of them. Imaging workup of degenerative disc disease in plain films. In plain films, you see narrowing of the interarterial disc space is kind of the landmark. And then you start seeing end plate erosions with reactive osteosclerosis and formation of osteophytes. And then you see sometimes you see intradiscal calcifications or vacuum phenomenon. So the early degenerative changes within the discs cannot be detected by radiographs. So this is just an example to different patients of what it looks like. So you compare these quote unquote normal looking interarterial discs here at L2, L3, and you compare it with L4, L5, and L5S1, you see that there is extensive contour irregularity of the opposing end plates. You see osteophyte formation, you see height loss, and you see this air or gas component there, which is the vacuum phenomenon. Same story here. You see that there is, we're going to talk about the posterior elements later, but you see there is an anterolisthesis, and also height loss of the interarterial disc space, sclerosis, and vacuum phenomenon. Those are the classic findings that you are used to see on a X-ray on plain films for degenerative disc disease. Now, imaging workup for multi-detector CT, computed tomography, it is pretty much the same. The findings are similar, narrowing of the hello? All right. doesn't matter. So the narrowing of the interarterial disc spaces, end plate erosions, osteophytes, the same findings. But the advantage of CT is that it allows you to scan the entire volume of the vertebral column. And then you can have multiplanar reformats in cases that you need to better characterize a given finding. And also it is very good for surgical planning. So surgeons can get like a better assessment of what's happening, the balance and the alignment problems, and then they can plan a surgery accordingly. So this is a CT image of the lumbar spine, and you can see that there is like asymmetric narrowing of the interarterial disc space. You see the vacuum phenomenon, osteophytes, a little bit of scoliosis there, as well as degeneration of the posterior elements. But the findings are pretty similar to those of the plain films. The MRI is the most sensitive imaging method for the evaluation of the discs, and it gives you an excellent contrast discrimination, soft tissue resolution and multiplanar imaging capability. And the description of the imaging findings must follow the standardized terminology. And I know you're pretty familiar with this paper. This is an old paper, 2014, is 10 years old now. And it's called the lumbar disc nomenclature version 2.0. So this is what we use here. And this is the PMID if you want to take a look. And this is what I'm gonna describe right now. So spondylosis deformans are the osteophytes that arise from the vertebral ring apophysis. This is the term, this is the definition. And it also includes the degenerative process of the annulus itself, whereas the intervertebral osteochondrosis has to do with the nucleus pulposus and the end plates themselves. So desiccation, fibrosis, and narrowing of the disc space, etc. So this is the spondylotic changes. You see as the disc that gets degenerated and it starts having volume loss, then the annulus fibrosus starts pulling on the Sharpey's fibers at the end of the ring apophysis, and that stimulates the proliferation of osteoblasts and osteoclasts, and then it results in the formation of peripheral osteophytes, the marginal osteophytes here. That's the spondylosis. And here the osteochondrosis is pretty much the degeneration of the end plates and the nucleus pulposus of the disc, resulting in sclerosis of the subjacent bone, and also the sclerosis, and also the formation of small nodes, etc., and gas phenomenon, vacuum phenomenon. So here you can see the osteochondrosis happening here along the opposing end plates, and the spondylosis with the formation of these big, bulky marginal osteophytes. The modic end plate changes, the modic classification for end plate changes, the modic type 1, 2, and 3 correspond to edema of the bone marrow, fatty replacement, and sclerosis, respectively. So when you have degenerative changes in the acute phase, you will have a bone marrow edema. As you can see here, the bone marrow shows high signal intensity on T2 adjacent to the opposing end plates, and then you have the corresponding T1 hypointensity. And you can see this disc is desiccated, low signal intensity on T2, and there is height loss of the disc, and then you see a horizontal fissure here on the posterior annulus. The type 2 modic changes is when the edema or the first acute episode improves, then that bone marrow, it gets replaced by fat. So it's still hyper intense on T2, but it becomes hyper intense as well on T1 because of the fatty component. So after multiple repeated episodes of acute inflammation, the bone marrow that is surrounding that end plate becomes fatty, and then that's the modic type 2 changes. And then after multiple repeated episodes of inflammation and improvement, then that bone marrow becomes sclerotic, and then you'll see it as hypointense on T1 and hypointense on T2, and those are modic type 3 changes. Annular fissures, the annular fissures are separations between the annular fibers, or between the annular fibers and the osseous attachments. And the classification that that paper proposes is the concentric, radial, or transverse. And they are not necessarily secondary to an acute injury. I'm going to show you the classification. So this is the annulus. So if the fissure goes like in the horizontal plane, that is called a transverse fissure, like on the axial plane. If it looks like when you're cutting a slice of cake from the birthday cake, that is called a radial fissure. And if it follows the orientation of the parallel annular layers, that is called a concentric fissure. So why don't we call them tears? We don't call them tears because when you say tear, it implies like a ripping mechanism, like something acute. And as we know, this may be chronic and degenerative in nature. So we just go with the word fissure. Here, this is a T2. This is on sagittal stair, axial T2, images of the lumbar spine. And I want you to see this area of high signal intensity at the posterior annulus of the L4-L5 disc that I'm indicating here. And then you can see on the axial plane that it goes on the it's kind of oriented in the coronal plane. So this is the appearance of a concentric annular fissure, a concentric fissure of the posterior annulus of this disc. Herniations. Herniations are localized or focal. This is very important. Localized or focal displacement of disc material beyond the limits of the interarterial disc space. Okay, so this is very important because what defines localized or focal? The extension of the disc has to be less than 25% of the disc circumference, or 90 degrees of the periphery of the disc in the axial plane. So there are two types. When you are reading an MR of the lumbar spine, you shouldn't be saying herniation. When you see a herniation, you have to determine whether is it like a boy or a girl type of thing, right? So when you say herniation, you have to say it's either a protrusion or an extrusion. The protrusion is pretty much, this is the transcription of the paper, but a protrusion is like when you're like driving your car and you go through a bad road, and then one of the your car tires just hit a pothole on the road, and then you just see that there's like a little bump on the tire. That is a protrusion. So the definition is that the greatest distance between the edges of the disc material protruding from the space into the spinal canal is less than the distance between the edges of the base. I'll show you the like a drawing of what it means like. And an extrusion is like when you remove the lid of a toothpaste tube and then you squeeze the tube and all the toothpaste just rushes out of the tube. That is an extrusion. So that distance is greater than the base. So I'm gonna show you what it means. And there are intravertebral herniations, which are the Schmoll nodes. So on this case, I'm gonna try to get my pen here. So you see that if we divide the disc into 4 quarters, if we divide our disc into 4 quarters, this herniation is less than 90 degrees, or 25% of the disc, so it's a herniation. And then the base of the herniation, the base, this distance here, which we're gonna call A distance, the base is much wider than the height, which we're gonna call B. So A is wider than B. This is a protrusion, and this concept applies for any plane. So here you see that this looks like a bump in the disc, okay? Now, this is an MR of the lumbar spine, T2 images. You see here, this bump here on the disc. You see the bump. Let me remove this so you can see it better. So you see the bump there, and you see that the base is much wider than the height. So that is a protrusion. That is a protrusion. Now, an extrusion is still less than 25% of the circumference of the disc, but the base is much narrower than the height. So this is when the toothpaste analogy. So the disc just got squeezed out of the disc space. This is an extrusion, an extrusion. And when an extruded fragment lost its connection with the disc, it's called a sequestration, okay? So this is a sequestration. So when the disc material just loses contact with its disc, okay? So you have to talk about migration when you have an extrusion. An extrusion can migrate downward or can migrate upwards or can migrate laterally. So you have to talk about the migration of the extruded fragment. All right, so this is an MR of the lumbar spine, and then you see this bulky extrusion getting outside of the interarterial disc space. And then you see here on the axial plane, the actual extrusion here. So that's the difference between an extrusion and a protrusion. So you have to classify the herniations, either extrusions or protrusions, depending on their location. So if the herniation is located like in the midline, you say central. If this like underneath the facet joint, you say subarticular zone. You don't say paracentral, you say subarticular. If it's in the foramen underneath the pedicle, then you see the foraminal. If it's outside of the pedicle, you say extraforaminal. That's very important for the clinicians and the surgeons for surgical planning. And on the coronal plane, you have to tell them whether the herniation is at the disc level or is infrapedicular, or if it went suprapedicular or is at the pedicle level. So you have to tell them where in the sagittal plane the herniation is located at. So here, just to draw a parallel, this is a protrusion on the left side, this is a protrusion, and this one on the right side is an extrusion. And these ones are the intravertebral disc herniations. They are also called Schmoll nodes. So what happens is that the end plate gets weakened over time, and then the patient, undergoes either like an axial load force or something happens, and then the nucleus pulposus herniates into the vertebral body. They are called Schmoll nodes. They can be acute or chronic depending on whether or not the patient has edema around it. So here you see the disc herniation here. These are super common for those of us who read MR of the spine. This is like an everyday finding, like the Schmoll nodes, intraarterial disc herniations. Now, what is a disc bulge? A disc bulge is when the disc goes beyond this interarterial disc space, but it is more than 25% of the circumference. That's very important. Less than 25% of the circumference is a herniation, and then you have to tell them whether it's a protrusion or an extrusion. More than 25% is a disc bulge. So here, this is the normal configuration. The dotted line shows the ring apophysis, and then you see the disc. The disc is within the confines of the interarterial disc space, but on this figure, we see that the disc goes beyond the interarterial disc space, but it's more than 25% of the circumference. This is a bulge. And when you have patients with scoliosis, you can have asymmetric bulges toward one side. So they can be symmetric or asymmetric, but if they're more than 25% of the circumference of the disc, they are bulges. So here you can see this is an axial T2, and I just brought this image so you see what the vertebral body looks like. And as I scroll down, you see that this dark stuff, which is the disc, goes beyond the limits of the disc space. You see that? It's like beyond. This is a disc bulge. All right, I'm done with the discs. Now we're gonna talk about the degeneration of the posterior elements. So this is the drawing. So you remember that I told you that as you grow older, As you grow older, your disc degenerates. So this is the midline drawing, and this is the parasagittal drawing, okay? The parasagittal. So this is a healthy patient. This is like a very proficient athlete, 18-year-old gold medalist, okay? This is normal as it gets, okay? So this is the anatomy. So here you can see number 6. Number 6 is the dorsal nerve root. Number 7 is the ventral nerve root. Here we have the artery and vein, the radicular arteries and vein, and surrounding them we have fat. So all of that here is within the sleeve, the nerve root sleeve here. Then you cannot see that on MRI, but you see the package here, and then you see the fat surrounding it, okay? Now, number 14 here is the annulus fibrosus. Number 1 is the nucleus pulposus. And then we have number 4 is the superior articular process. Number 4 is the superior articular process. Number 3 is the inferior articular process of the upper vertebra. You can see here, number 3, right? And then you have the synovial joint here, right? The synovial joint. And this is a little bit of the joint space here. And you see the synovial joint here, right, of the facet joint. And you have pedicle, 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 and that's our anatomy, and that is going to be our baseline for the discussion that follows, okay? Pathophysiology, pathophysiology. So as you grow older, this is the normal one on the left side, okay? As you grow older, then your nucleus pulposus starts dehydrating, desiccating, and then it loses its height. When it loses its height, then you start having bulging of the posterior annulus, bulging of the posterior annulus. And when you lose that height, then you also approximate your pedicles. And when you approximate your pedicles, then you see that the superior articular process is going to migrate cephalad in a cephalad direction, and the inferior articular process is going to go in the caudate direction. And there is going to be a little bit of a AP displacement of the vertebrae as well because of this motion. And this very tip of the bone here is going to start rubbing against the pars interarticularis, okay? So, and all of this started just because of aging, okay? So this is number A, okay? So let's see what happens next. This is A, okay? So numeral B. So with the time, you keep on losing height of the intervertebral disc space. You keep losing height because you're still aging, right? And then this disc bulge is getting more prominent, and it is occupying the inferior part of the neural foramen. All right. What happens in the posterior elements? The posterior elements, you get a pseudoarthrosis here. This bone that is rubbing against this bone is creating like sclerosis, bone sclerosis, and then there is like an extension of the joint space here, and then this cartilage is getting degenerated, and then you are getting degeneration of the facet joint as well, and the tip of the inferior articular process is also hitting the pars interarticularis of the lower vertebrae and generating a pseudoarthrosis here as well. Numeral B, this is numeral C. Then you see that over time, your intervertebral disc space is almost collapsed. And when it is collapsed, you start getting osteophytes here, right? The Sharpey's fibers start pulling, and then you get osteophytes here, you get osteophytes here, you get a disc bulge here, which is narrowing the inferior aspect of the neural foramen. The pedicles are getting closer together. The pedicles are getting closer together. So the neural foramen is narrowing in the cephalocaudal direction as well. And now you have an osteophyte formation here because of the pseudoarthrosis here and the sclerosis here. And here you also see that there is osteophyte formation here, and there is progressive sclerosis and erosion of the pars interarticularis. This is numeral D here, numeral C. At some point, you may even get a synovial cyst from here, right? Which crowds a little more the neural foramen. You see that the fat is going away. And then you have this osteophyte here as well. You have progressive narrowing of the interarterial disc space. You have osteophytes here. You have a disc bulge or a disc herniation here, and everything here is getting more and more crowded. You can also have a synovial cyst on the outside. You can see those pretty frequently. And what happens if that not only happens here, let's say this is L4 and this is L5, which is always like a widespread phenomenon, right? So it also happens here. So you see that this piece of bone here, which is this piece of bone here, is also narrowing the pars interarticularis here. You see the narrowing of the pars interarticularis there. And at some point, that pars interarticularis just breaks, right? This is a degenerative spondylolysis. This is the pathophysiology of a degenerative spondylolysis. At some point, this guy fails and then just breaks, right? And then you get the anterolisthesis, right? Sometimes it's just you just get a fracture here, and when that fractures here, that fragment just fractures, then it results in a fracture here, and then the osteophyte just falls here and just crowds even more the neural foramen. Here you start getting modic type 1 and 2 and 3 changes here on the disc. There is complete collapse of the disc. There is bulging of the neural foramen, and all of that contributes to foraminal stenosis. What happens in the midline? In the midline, you get this osteophyte formation here, osteophyte formation, and then you get disc bulge, right, at the same time. And then this is what is called the pancaking of the interarterial disc. So it all results in narrowing of the AP dimension of the interarterial disc. When you have height loss of the disc, you also have approximation of the spinous processes here, because when you lose height here, then the spinous processes also come together, and then you get pseudoarthrosis of the interspinous space, which is called the Baastrup's phenomenon. Then you also have some inflammatory, reactive, or degenerative inflammatory process here, which also contributes to the spinal canal stenosis. All right. So at the very end, you result with a very crowded neural foramen. So this is pretty much what I told you what was happening. So there is a vertebral end plate approximation with the degeneration of the disc, then pedicular approximation with narrowing of the neural foramen, and then progressive degeneration of the facet joint with subluxation. And the osteophytes also contribute to the neural foramen narrowing. And then you have a pars defect and spondylolisthesis. So this is a normal MRI that I showed you at the beginning. And here, this is just mild changes. You see that there is mild, degeneration of the facet joint. Then you start seeing bulging of the disc, and you see how the fat is starting to get narrow here. You see that? Like same story on the T1. Compare that with the normal appearance of a neural foramen. So this is just the very mild changes. And as the time goes by, you get a disc bulge or a disc herniation here. The degeneration of the facet joint is much more prominent. You see that the fat is getting effaced, and this nerve here is getting squeezed there, right? So, and as the thing gets worse, you'll see that you already have modic type changes here. You have modic type 1 changes along the opposing end plates there. You have degenerative disc collapse. You have a disc bulge. You have like a very bad facet joint arthropathy here. And you see the poor nerve here is just being squeezed somewhere here in between the facet joint and the degenerative disc. That's a severe neuroforamen narrowing, and you can compare that with this normal appearing foramen here, right? And then you see this is the end result. You see you don't see any fat here. You can see the nerve here a little bit, but you don't even see the nerve. The nerve should be somewhere here, and you see this degenerative disc, degenerative effusion of the facet joint here as well, and you see all the degenerative changes of the disc at that level. You see here the degenerative effusion of the facet joint, and then you see the internal synovial cyst. You see this cyst is compressing upon the descending nerve root at the lateral recess there on the axial plane, all belonging to the same pathophysiology of the degeneration of the posterior elements. Now, just a couple of slides about spinal canal stenosis. The definition is that there is no standard definition, okay? So like there are many different groups that use different scales to determine what, you know, the severity is. The most used criteria, there are some people that like measuring it, like the quantitative approach. You know, people say that the AP diameter of the spinal canal in the mid-sagittal plane should be more than 12 millimeters. But people usually, at least in my institution, the surgeons like the qualitative approach better. So pretty much if you still see CSF surrounding either the conus or the cauda equina, if you still see a lot of CSF, that is probably mild. If there is effacement of the CSF on one side, but there is still a little bit of CSF in between the cauda equina nerve roots or something, then you see moderate. And if you see no CSF at all, that's severe. But again, it depends on the clinicians and the surgeons you are working with. The most important thing is just for you to be very accurate in your description and tell them whether or not, you know, there is still CSF, there is crowding of the cauda equina, and what's happening with the conus, etc. The same story with the neuroforamen. If you still see fat surrounding the nerve, that's probably mild. If the nerve is partially surrounded with fat, it's probably moderate. But if you see no fat surrounding the nerve on the neuroforamen, that's probably severe. But again, there is no consensus. So for example, on this one, you see a disc bulge here, right? Then you also see facet joint hypertrophy. You see thickening of the ligamentum flavum, and then you see that there is crowding of the cauda equina nerve roots here, but there is still some CSF there. So some people may say, well, this is moderate. Some people may say, well, but the lateral recesses are collapsed, so that's severe. So it's just a matter of communication and just have like a two-way communication with your clinicians and surgeons. So you all know what you are talking about when you are reading your reports. Same story what we were talking about. So conclusions. The degenerative changes of the interarterial discs and posterior elements are a combination of normal aging, biomechanical factors, genetic traits, and environmental effects. The discs and posterior elements are a single functional unit. You see aging and degenerative changes of the disc result in progressive degeneration of the posterior elements. That's a fact, okay? And there is usually a poor correlation between the imaging findings and the symptoms. That is something that we have to deal with. That's why it's very important for us to have a very good communication with our referring physicians. And the role of imaging is mainly to identify lesions amenable for surgical or percutaneous or medical treatment. That's very important. All right, so 45 minutes, I took 45 minutes as promised. Thank you very much. This is a panoramic view of our medical school here in Shreveport at Louisiana State University. And I'm glad to take any questions from the audience.
Okay, that was great. Thank you, Dr. Arbelo Espejo. So it's wonderful to hear all your detailed and illustrative presentation. I thoroughly enjoyed it, and I trust our audience did as well. And I should say that I really appreciate the time and effort you dedicated to explaining the essential details of the anatomy and pathophysiology related to low back imaging. So it was a wonderful presentation. Thank you again.
Thank you very much.
Yeah. So now I would like to open the start the question and answer session. If you guys have any questions from Dr. Hello, so that's great. Okay, there's one question from Chaudhary Ashok. The question is, sir, is protrusion divided into focal and broad-based?
That's a great question. That was a topic or like a terminology that was used before the 2.0 version, and I know that some people still use it. And then it is not used anymore because it may create some confusion regarding extrusion versus protrusion. Back in the day, some people used to call broad-based protrusions to protrusions and narrow-based protrusions to what today we call extrusions. So right now they try to simplify things. The same story with annular bulges, like a broad-based bulge or a narrow-based bulge. Now we are just saying like just bulge, because bulges are usually not treated on their own. If they're combined with other findings that result in spinal canal or neuroforaminal stenosis, they need to be treated. But now we just use the word protrusion and extrusion. That's it. That just plainly, and we try not to use the word herniation because of the same problem. It creates confusion about the nature of the finding. So we just say protrusion or extrusion, and that's it. That is what we are using today.
Okay, so far I don't see any other questions. But again, it was a great, wonderful presentation, and I hope the audience enjoyed it. So maybe we can give 1 or 2 minutes for the audience. Maybe they might have a question. And yep. Okay, so there's another question from Rosalie. So can you explain the compression existing nerve and traversing route in same level?
All right. That's very important. That is a very good question. I try to keep it like as simple as possible. So just avoid, you can have like a lecture of 3 hours, talking about this. So, all right. So this is the let's think that this is the thecal sac. This structure here is the thecal sac. So this guy here, like the shoulders of the just think of this like a centipede had a sweater, okay? So this is the shoulders, right? So this is the lateral recess, right? So when you have a herniation here at the subarticular zone, then that herniation is probably gonna affect this nerve here. Okay, let me just erase this. So let's say that this is L4 and this is L5, okay? So this nerve here is L4, right? This spinal nerve here, and this nerve here is gonna be L5, okay? So if I have a herniation here that is affecting the lateral recess here, right? That herniation, even though that herniation is at the L4-5 disc, this is the L4-5 disc, okay? Is affecting the descending 5 nerve root, right? But if the herniation is here at the level of the foramen, or the extraforaminal zone, that herniation is going to be affecting my L4 spinal nerve. I don't know if that makes sense. So that's the same level herniation. That's why it is very important for us to tell them where the herniation is on the axial plane, because the subarticular zone is going to hit the traversing nerve root, who is going to exit downstairs. but if it's in the foraminal or extraforaminal zone, it's gonna hit the nerve that is exiting at that stop. It is just much easier when you are on a workstation because you can just scroll through it. So here, for example, here, you see that this nerve is exiting right there. So this nerve is getting ready to exit at the next stop, but this, let's say that this is L4, okay? So this is the L4 spinal nerve getting ready to exit, whereas this is the L5 that is gonna exit the one below. So if you keep scrolling, if I had a like a scan here to show you, I could show you, as it exits, it pierces the lateral recess on its way out in the next level. So that's pretty much the reason why they created this division. Yeah, this classification. I don't know if that answers your question. It's kind of complex. You need to be at a reading room, in a workstation just with a full scan just for to show you, or with a myelogram.
Okay, so also I just saw the kind of request was asking can you share the article?
Absolutely, I will do. Yeah, I will do. I will have to find it, but I'll send it to Dr. JP so he can just distribute it among the audience.
Yeah, that would be great. Okay, so far I don't have any more questions. Thank you so much again for all your time and dedication for the session. Thank you.
Oh yeah, so you're welcome. Thank you very much for the invitation. Thank you.
Thank you so much, Dr. Octavio. I mean, it was a great lecture, especially with your personal illustration and drawing that on images, graphical images, and you kind of correlated that with MR. Wonderful lecture. Thank you so much.
Yes, very wonderful lecture. Thank you.
Yeah. Thanks, Terry. Okay, so and I just wanted to thanks Dr. Ondrak too for moderating this session. Thank you so much for taking time and doing that. So can we do the quiz session after such a wonderful lecture? I guess this question should be a pretty cakewalk, I guess. So, and again, before I ask what this question is, make sure you scan the QR code and answer these questions. Please do not answer or type your question in the Q&A or chat box. Make sure you just type the question answer only in the QR code after scanning it in your phone or in your device. So what type of vertebral body changes you see in this image? And you have 2 minutes to answer. Is it Modic 1, Modic 2, Modic 3? Or is it a fracture or is it a metastasis? So you have another 1 minute 45 seconds to answer this question. What type of vertebral body changes? You see 2 images here. And make sure you again scan the QR code and answer this question. Pretty straightforward question there. Last 1 minute. What type of vertebral body changes? Modic 1, Modic 2, Modic 3, is it a fracture or a metastasis? Last 30 seconds. Last 15. All right, time up. Thank you. Can we have the answer, please? All right, the answer here is option B, which is Modic type 2 changes. And this represents normal red hematopoietic bone marrow conversion into yellow fatty marrow as a result of marrow ischemia. You see this again, both T1 and T2 hyperintensity. The first image on the left is T2. The second image is on the T1. At the level of L3, L4, you see hyperintensity in the end plate on both the images, which is consistent with Modic type 2 changes. All right, thank you so much for everyone who's attended this and answered this question. Can we get the QR code for the evaluation, please? All right, there is the evaluation form. Please make sure you scan this QR code, and the certificates would be issued only to those who have completed the evaluation. So please complete the evaluation. And again, just a very quick reminder about our next session. We have 3 more sessions. The next sessions is something, the heart radiology topic, which we had selected, the next three sessions. It'll be very interesting. The first session would be on Sunday on September 22nd, 3 weeks approximately from now. And it would be on imaging of ovarian cancer. So same time, please make sure to log in at the same time on September 22nd for the next lecture. Anything else, Dr. Turpening, Nat, do you have anything else to announce? If not, I guess it's been a great lecture. Thank you so much for everyone, for all the attendees who have attended this lecture. And thank you so much for the panelists, the IT committee, for having worked and make this a success. Thank you so much.
Thank you so much, everyone. Thank you so much, JP.
Thank you. Thank you, Dita.
Thank you. Bye-bye.
Thank you so much. Thanks again, Dr. Undrak. I'll keep in contact with you. Thank you.